Hello and welcome everyone to our update on COVID-19. In this particular presentation, we will not be covering the points like clinical presentation and all which we have already covered in our previous presentation. We will be focusing on the new information and the current management that has to be done in critical care for these particular patients. Now let's remove the confusion regarding the SARS-CoV-2 and the COVID-19. Just like in HIV and AIDS, the SARS-CoV-2 is the virus, while COVID-19 is the disease process. So we have around 7, 8 coronaviruses which are causing infection in humans, but this particular one belongs to the beta corona group with a lineage B. It has almost 80% genetic similarity with the SARS-CoV and 50% with the MERS, and 96% to a bat coronavirus. Probably this is the rumor regarding the bat soup being the cause of transmission. But that is not the reality. We still don't know how the infection was transmitted from the animal to humans. The receptor for the SARS-CoV-2 is ACE2. So this is the report released by the CDC of China on COVID-19. It includes almost 72,000 patients, and as of February 11th to 2020. So they had around 62% confirmed cases. That means these were the cases which were detected by RT-PCR, and almost 16,000 patients had suspicion of infection. They were never tested because the facility for doing the test for SARS-CoV-2 was overwhelmed. And we have around 900 patients, that is 1%, who were asymptomatic carriers. So these patients never developed any symptoms but were found to be positive for this virus. Most of the cases are between the age group of 30 to 80 years, almost 40,000 cases. The case load below the age of 19 is only 2%, and probably the children are getting less affected in this particular virus. Now coming to the spectrum of disease, 81% of the patients had only mild symptoms. Only 5% had critical illness. So nearly 2,000 patients had critical illness or patients who needed ICU admission. Severe case around 14%. These are the patients who would need admission to the hospital and monitoring. The case fatality rate among these 44,000 cases is around 2.3%. 14% of these, it is around 14% in age group more than 80, and from 70 to 79 it is 8%. And in critical cases, that is in this 2000, that is 5% of the total cases who got admitted to the ICU, the mortality is around 50%. So this disease, though mild, the patients who do get admitted to the ICU, they have a very high mortality rate ranging from 40 to 50% based on various studies, and slightly higher mortality than the average mortality we get in terms of ARDS patients getting admitted to the hospital. And as we can see, as the age increases, the mortality rate has also increased. Do keep in mind that most of the mortality that we see over here is from China, and the mortality rates outside China have been quite less, almost to the tune of 0.4%. But recently there has been an increase in mortality rates, especially from cases reported from Italy. We still don't know the details, so right now we take for all practical purposes that the mortality rate is between 2 to 3%. Maybe higher or maybe lower, we still don't know. We have to wait for further information. Now, regarding healthcare personnel getting infected, nearly 3.8% were infected out of the 44,000 cases. 63% were from the Wuhan province. And the most important part which we need to know is nearly 15% of these cases, that is nearly 250 people who were healthcare professional got admitted to the ICUs and required therapy, and unfortunately 5 have already died from this particular process. Now, regarding transmission within the hospital, in one study, 41% of patients were presumed to be due to hospital transmission. Out of this, nearly 30% were healthcare professional and 12% were patients hospitalized for other reasons. Now, this graph shows the how the cases have evolved and when they got detected. The initial cases started getting detected from the second week of December, and there were sporadic cases until the 31st, and it was only on 26th of December that particular Dr. Zhang detected 4 unusual cases of pneumonia, especially 3 from the same family. That is when he actually contacted local CDC, and then the investigation into this particular thing started. And as you can see, the Hanan sea market was closed by the 1st of Jan, and WHO was really into it, and by 30th of Jan we know that it is already a public health emergency. And almost China has done a lot to keep the disease under control. They have extended their holidays, the Lunar New Year, and the whole Hanan city seafood market and the Wuhan city were almost shut down to prevent the disease from spreading. Now, if we look at the pathophysiology, there have been very few histopathological studies, but there's just one which was reported from a postmortem case. We don't see much histopathological damage in terms of COVID-19 if you compare it with the MERS virus. What they found was diffuse alveolar hemorrhage and no specific histopathological changes in the heart. So the lungs did not really have much information, especially in that small study. Now, if we compare how the disease is different from SARS and MERS, all the 3 viral infections commonly present with fever and cough, which frequently lead to a lower respiratory tract infection. Poor clinical outcome is associated with older age and underlying disease health conditions. SARS has been told to be contained since 2004. MERS is not yet contained. COVID-19 seems to have a higher number of mortality, but less severe infection, and this is because of the high rate of transmission of this infection, which could be because of the less severity of infection, where we have a lot of mild and asymptomatic cases who do not come to the health facility and stay in the community and keep on spreading the infection. And MERS and SARS had a very high nosocomial transmission rate. As of now, the nosocomial transmission rates we have seen in COVID-19 are slightly lower. We're getting a lot of cases from the community rather than from the nosocomial setup, as had been the case with MERS and SARS. Now, for MERS and SARS, MERS was again found in the Arabian Peninsula with exposure to the camels. It has, for that you need you required airborne and contact prevention. For SARS also we required airborne and contact prevention. As of now, for novel coronavirus, we know that droplet in prevention is enough, and obviously contact prevention has to be done. Airborne prevention is to be done only if certain procedures are to be done. Now, from SARS outbreak in 2002 to the COVID-19 in 2019, we can see that the response rate from China and WHO has been much faster this time. Last time the first case of SARS was detected in November, but by the time WHO got an alert and got to know about the cases was in February, almost 3 months, and it's only after 1 month that they declared it as a global alert. So almost 4 months had passed before the world came to know about the disease and took preventive measures. This time it has been very fast. Just though the first case was detected in December 8th, it was difficult to know it was a different virus, and because it was a very sporadic presentation. So, but by December 31st, China had notified to WHO about this new virus, and it was identified by Jan the 7th, and a global alert was initiated by Jan the 30th. Now, what infection prevention and control measures are to be done if a particular patient comes to the healthcare setup? This is what we will discuss first, then we will go into the management. Now, healthcare workers may be at increased risk. Early respiratory infection symptoms can be non-specific. So, thus, the healthcare workers may not be prompted to implement additional precautions to prevent transmission while providing care. Hence, the importance of standard precaution, because the symptoms that are associated with SARS-CoV-2 are non-specific and very, very common and can be found in many, many more respiratory diseases. So there is no reason to be uh, putting those precautions for all patients. So maintain the standard precaution. So as of now, use standard precaution for all patients in all settings and at all time, regardless of the symptoms. These include hand hygiene, respiratory hygiene and cough etiquette, use of personal protective equipments based on the risk assessment, safe injection practices. Now, how do we triage? Early recognition of a patient with SARS-CoV to have a high level of suspicion for the COVID-19. Give the patient with suspected infection a medical mask. Place the patient in a separate area. This will contribute to the source control and diminish the potential for environmental contamination. Ensure a well-equipped triage station. Institute screening questionnaire according to the COVID-19 case definition. Organize the space and process to permit spatial separation of at least 2 meters between each patient with COVID-19 and other individuals. Post signs in public areas reminding symptomatic patients to alert the healthcare workers. Ensure that triage and waiting areas are adequately ventilated. Encourage respiratory hygiene, covering the mouth and nose during coughing and sneezing, either with a tissue or a flexed elbow, followed by immediate disposal of the tissue and hand hygiene. When admitting patients to the ward, ensure that only those with confirmed infection are placed with other COVID-19 confirmed cases. Now, healthcare workers caring for patients with COVID-19 should apply droplet precaution to prevent transmission of virus via large droplets. So, what are the droplet precautions? Place the patient in a single room, or when not available, group them together with the same or similar diagnosis. Keep patients spatially separated by at least a meter or 2 meter. Single room or ward should be adequately ventilated. Use medical masks if working within 1 to 2 meters of the patient. Use eye protection if you're providing care and having a close contact with the patient. After the patient care, appropriate doffing and disposal of the PPE and hand hygiene should be carried out. A new set of uh, personal protection equipment is needed, and when care is given to a different patient. Limit patient movement within the institution and ensure that the patients wear medical masks when outside their rooms. Now, in addition to transmission by droplet, COVID-19 can be transmitted through contact. So use all the contact precautions like use of personal protective equipment when entering room and removing it when we leave. Use of dedicated and disposable equipments. Do not touch the patient, avoid touching them as much as necessary. Clean and disinfect any shared equipment. Avoid contamination of the patient environment. Have an adequately ventilated room. Do proper hand hygiene and avoid moving the patient around too much in the institution. Now, there are some situations when we have to go for airborne precautions as well. In that, use the personal protective equipment like gloves, long sleeved gowns, eye protection, and particular respirator like N95 masks. Use adequately ventilated single room when performing aerosol generating procedures. Now, what is a negative pressure room? It means that there is a minimum change of 12 air per hour, or at least 160 liters per second per patient in facilities with natural ventilation. Ask all people not required for the task to leave the room. Contacts of confirmed cases may identify people who test positive but have no symptoms. Until more is known, people who are found to be positive RT-PCR testing should be isolated, followed up daily for symptoms, and tested at least weekly or earlier if symptoms develop. So, how long we keep them isolated? It should continue until two consecutive upper respiratory tract samples taken at 24 hours apart come negative for RT-PCR. Until then, the patient must be isolated. Now, how do we diagnose? Uh, Here we have some criterias, like suspected case is one who has a symptom of acute respiratory illness and a history of travel to the area reporting COVID-19 in the last 14 days. Acute respiratory illness and contact with a confirmed and probable case of COVID-19 in last 14 days, a patient with severe airway respiratory infection and requiring hospitalization with no other etiology that fully explains the clinical presentation. So in all these three cases, you have to suspect a COVID-19. A probable case of COVID-19 is a suspected case in whom testing for COVID-19 is inconclusive, and confirmed case is one in which you get a lab confirmation of COVID-19. This is irrespective of what is the clinical signs and symptoms of the patient. How do we do a lab confirmation? It is done by the RT-PCRs for the SARS-CoV. Now, the Indian Council of Medical Research and the National Institute of Virology has come up with guidelines how and we should collect the samples and how to we send. So this is how it is done. They also have given their phone numbers and all. So select the cases as we have told. Any patient who has a history of respiratory infection or having gone to the cases places where cases have been reported in the last 14 hours. Previously it was only in Wuhan, China, but currently cases have been reporting all over the world and all over India. So if they have visited states which are reporting the cases, they should be suspected of having these infections, especially if they have gone there in the last 14 days. Now, what samples we need to send? We need to send definitely a nasopharyngeal or oropharyngeal swab for the upper respiratory tract. For lower respiratory tract, you can send either the sputum sample if the patient is non-intubated, but if the patient is intubated, you can go for a tracheal aspirate. We would recommend to go for a tracheal aspirate than going for a bronchial level lavage, because a bronchial level lavage would be a more aerosol producing in procedure and maybe causing more collateral infection to the healthcare professionals. So preferably go for a nasopharyngeal or oropharyngeal swab, tracheal aspirate, and serum samples. These are the three samples you need to send. They have given an elaborate method how you should collect, package, and transport these samples. And with also they have given information regarding who is the contact person, the email IDs, everything has been given, so so that you can complete the process properly. Now let's come to what is the management that we can do, especially in critical care setup. So there is a singular study in which they have done the severity scoring. In this, they have graded the parameters like age, respiratory rate, oxygen saturation, supplemental oxygen, systolic BP, heart rate, consciousness, and temperature. Based on the points, they have done a severity scoring. So a score of 7 or more is considered to be the patient is very sick and requires an ICU admission and requires continuous monitoring. So this is something which can be done at the emergency level, so that the patient can be assessed and sent to the ICU based on the severity of the illness. Now, what therapies we can start? So to start off with, since most of the patient present with ARDS, we would be requiring some kind of a ventilatory support. So NIV in H1N1, the evidence that we have is this is an observational study in assessing around 806 patients. Out of this, nearly 60% of the patient required a conversion to invasive ventilation, and a SOFA score of 5 or more was associated with high risk of NIV failure. Mind you, NIV failure was associated with increased ICU mortality compared to invasive mechanical ventilation. In MERS, 302 critically ill patients, NIV was used initially in 35, but almost 90% required to be converted to invasive mechanical ventilation. Now, in a recent single-center RCT with unselected patient with ARDS, they showed that helmet NIV resulted in significant reduction, but this particular study was very small, and we cannot really use this data for our current practice as of now. Though helmet would be a better method, it is hardly used in most of the setups. Now, HFNO, limited trials in viral pneumonia, just single study with 25 patients with H1N1, and it has been shown to have same effectiveness as NIV in ARDS. So should we use NIV and HFNO? May be tried in mild cases, but we would definitely not recommend to use them inside the ICU. Prefer to avoid using them, and it is better to go for invasive ventilation, because with the NIV and HFNO you have a very high risk of airborne transmission and infection of the healthcare professional and other patients who are present there. Now, if we go for invasive ventilation, how do we manage the airway? Double check for indications for the endotracheal intubation. If required, prefer elective to emergency. Intubate these patients early. Do all your planning. Do not wait till the last moment when they crash, so that it causes problems. So do elective intubation so that you're better prepared. Now, how do you prepare your team? Minimize the number of team members. The most expert team member should perform the intubation and advanced airway control, and he should be present inside the chamber with a donned PPE. Expert assistant on protocols and devices, a nurse or a doctor should be present with PPE inside the chamber. A second doctor with donned PPE should be inside the chamber to help in case of a complex maneuver or a difficult airway, or if the plan goes not according to what is expected. Doctors available with donned PPE should be outside the chamber in case of help is required, and there should be an observer who should see how the donning and the doffing is being done of the PPE. Do carry out a preliminary briefing for role definition, so the people inside the room know exactly what they want to do and there is no confusion when the actual procedure is going on. Now, there are two levels of PP that are to be done. The second level, that is for airway management, you can do it with the N95 mask, face shield, long sleeve scrubs, double gloves, and overshoes. If you are going for an aerosol generating procedure like awake endotracheal intubation bronchoscopy, then you need a third level PPE. That is, you need to replace the N95 mask with a helmet. Now, a clinical checklist of how wearing the PPE must be included. Do a proper evaluation of the airway and oxygenation. Accept difficult airway management risk and overestimate it. If you are having any suspicion, always overestimate the risk of an difficult airway. Do a proper hemodynamic evaluation. Optimize the hemodynamics preemptively. Always, it is preferable to attach vasopressor and fluids at all if they were required prior to the intubation, so that you don't have the patient crashing and people having to rush into the room when the patient's BP is going down. So keep everything ready, then go for the procedure. Airway instrumentation, HME filter on every oxygenation interface. Airway card should be ready. Suction should be a closed system. Medication should be prepared, double checked and kept. Emergency card should be ready, and try to use disposable devices wherever possible. Now, coming to the procedure itself, pre-oxygenation to be done properly. Avoid bag mask and avoid to use cricoid pressure until and unless an actual regurgitation is going on. Go for rapid sequence intubation in all patients. Use nasal prongs at 3 liters per minute during the apneic phase. Give the full dose of neuromuscular blockade and respect the onset time for laryngoscopy. Do not attempt the procedure before the onset time, risking yourself for more aerosol transmission. Laryngoscopy should be done preferably with a video laryngoscope, so that you don't have to directly visualize and expose yourself to the virus. Reoxygenate the patient in case of failed attempts. with low tidal volume, and switch to a supraglottic device if at all required, and prefer a intubatable supraglottic device. And if at all nothing works, then you can go for a flexible endoscopy. And in case of cannot intubate, cannot oxygenate, go for early cricothyrotomy. Do not waste time. Avoid awake intubation as much as possible, but if it does become necessary, then go for airway topicalization. Avoid aerosols and vaporizers. Titrate sedation with an infusion pump. Use a flexible endoscope, preferably a disposable one with screen. Go for supraglottic devices if it fails, and early cricothyrotomy if there is any risk of cannot intubate, cannot oxygenate. Now, once you have intubated, what ventilatory settings are to be used? Not much difference from the standard ARDS protocol that we use. A tidal volume of 6, try to keep the plateau pressure less than 30, and titrate your PEEP individually. Regarding the use of high frequency oscillations, we already have two large RCTs which have shown that it doesn't really help in ARDS, but a meta-analysis showed that the response to the high frequency oxygenation was based on the baseline severity, and harm was seen among patients who had mild to moderate ARDS, but there is a possibility of decreased mortality in very severe ARDS. Prone ventilation, we have already seen the mortality benefits with the ProSIVA trial, and there is a similar study with the retrospective study of prone ventilation, especially in viral pneumonia, that is the avian flu, and this they found that prone ventilation improved oxygenation, which was sustained even when the patient was made supine. So prone ventilation is something which is really recommended and can be done. Definitely use neuromuscular blocking agents, as though there are no specific trials in viral ARDS patients, but we have seen the overall mortality benefit and the ventilatory benefits associated in general non-specific ARDS cases. Now, ECMO, it used started mainly after the H1N1 pandemic. Though the Eolia trial did not find benefit, its Bayesian analysis, which was published later, did show improvement with ECMO. Now, ECMO is likely to be associated with better outcomes if used among patients with limited organ failure and good pre-morbid functional status, and should be considered in patients who fail other evidence-based oxygenation strategies, and in individual patients with after assessing the risk and benefit, we can go for ECMO. So ECMO is definitely a therapy which will be and can be used in this particular group of patients, and should be used rather. Regarding cardiovascular management, timely adequate resuscitation is essential, but the most important thing that has to be kept in mind is the conservative fluid strategy. Do not pump in too much fluids. Try to keep your fluid extremely conservative. Myocarditis is a possibility and can be seen, and so keep that in mind when you're managing these patients. Mind you, till date, the number of deaths and the cause of death that has been reported for the COVID-19, nearly 2/3 is because of respiratory symptoms, but around 20-30% is because of the cardiovascular issues. So cardiovascular management is also very, very essential. Now, the treatment modalities that have been implemented in COVID-19 till now, antiviral has been used in a lot of cases. Use of steroid, we will come to whether it should be used or not. Renal replacement, continuous renal replacement therapy, oxygen inhalation, NIV, invasive ventilation, and ECMO have all been tried, especially in patients who have severe disease and requiring ICU admission. Now, antiviral therapy, till now, we do not have a specific antiviral therapy which actually works, but then there have been a lot of antivirus agents which have been used and have been shown to have benefits. So as of now, if you are using antivirals, and it is recommended to use antivirals, it has to be done in a setup of a clinical trial, and do a clinical trial if you are using a particular antiviral, because until and unless we have more data, it is difficult to know which antiviral actually works. So it is recommended to give antivirals, but do it also keeping in mind the research so that you can report the data. So the common one which are being used are the lopinavir and ritonavir. These are the anti-HIV agents. Oseltamivir is something which is being used for H1N1, and zanavir is something which is being recently used because there have been uh, resistance to oseltamivir in H1N1 in some particular patients. But remdesivir is something which is recently coming up for the use of COVID-19, and it has been used alone and in combination with interferons also. So these are all the antiviral agents which have been used. There have been other agents also, but these are, especially the top three, have been the most used antiviral agents as of now. And though not shown to be of clinical benefit or any evidence showing benefit, they can be and should be used in a patient coming with COVID-19 infection. Now, regarding other agents, there are lots of agents which have a antiviral effect and have been tried, but then again, just like the antiviral agents, these do not have evidence based, but they can be used. As far as antivirals are concerned, we would recommend they should be used, but for these agents, you can use or you cannot use. They definitely do not use corticosteroids, but because as of at least for ARDS purpose, corticosteroids can be used if you're managing it for shock, but for ARDS, especially viral ARDS, corticosteroids have shown to increase the viral shedding and worse outcomes with ARDS and viral infection. So it is better to avoid corticosteroids, especially if you are giving only for ARDS. Macrolides again have some anti-inflammatory and antiviral properties, so they can be used because as such you have to give some antibiotics to prevent the bacterial infection. Chloroquine has been tried, sirolimus, statins, IVIG, interferons, vitamin C, all these have been tried as anti-inflammatory measures, but none have been recommended. If you are using any of the agents, please keep in mind the research purpose. If you are doing it, then do it for a research purpose. It would be better for future, so that we know how has these agents have helped or didn't help in management of the cases. Now, although there is often no specific cure, three things have been most commonly used, that is antimicrobials. These are definitely recommended. Do give antibiotics because there is a very high risk of bacterial infection, and cover for community acquired pneumonia or healthcare pneumonia if the situation is appropriate. So it is recommended to go for antibacterial agents. Oxygen has to be given. Specific therapy for the underlying condition has to be done because patients with comorbidities are having increased risk of mortality, so try to control the underlying disease process. Now, as we have already discussed, there are a lot of compounds which are already licensed but not yet recommended for use in uh, COVID-19. They can be repurposed for these particular infection and can be used for research purposes. So, to conclude, care of critically ill patients with COVID-19 is based on usual management of viral pneumonia with some additional precautions. Many patients with COVID-19 developed ARDS, that is around 70% they do have ARDS. So, the evidence-based management of ARDS has to be performed. So, go for conservative IV fluid management strategy. Do start early antibiotics because there is always a possibility of bacterial pneumonia, especially if the patient has severe symptoms and gets admitted to the ICU. Consider for early invasive ventilation, do not try NIV and HFNO if the patient is getting admitted to the ICU. Go for long protective ventilation. Proning is something which has been shown to be of benefit and can be done. Do consider ECMO. In spite of the negative Eolia trial, ECMO can be tried and should be tried in patients who do not respond to the conventional evidence-based oxygenation therapies. Now, antiviral or immunomodulatory therapies have not yet been proven effective for treating COVID-19, but patients should be asked to participate in clinical trials for supportive and targeted therapies. So, thank you for your patience. and please check our website for further information. I think we have covered most of the things that is required for critical patients, though the results and reports are fast coming in. Maybe some things will be changed as the time passes, so do check the WHO and other governmental websites for updates and information regarding this disease process. Thank you for your patience.